Hi everyone, in this video I'll be discussing prescribing drugs during pregnancy. Now, why it is important that we should be worried when we prescribe drugs to a pregnant woman? The problem is when you give the drug will go to the pregnant woman. From the pregnant woman, it can go to the placenta. From the placenta, it can enter the fetus. Now, majority of the drugs can do that, and there is a risk of teratogenicity. So that's why we should not take a risk. So whenever you are prescribing in pregnancy, we have to follow some rules, some guidelines. So what are the guidelines? Let us discuss, and what are the important things you need to know when you prescribe during pregnancy, and it's a high yield concept for it. Now what I suggest you is watch this video once you have finished all the systemic pharmacology, because you will have a great idea when you have finished and when you see this video. So that is my suggestion for you, and let us start our journey. So prescribing drug during pregnancy. Number one, now try to give non-drug therapies. So the principles of prescribing is, suppose she has headache, simply she can apply the local Vicks, or she has running nose, simple steam inhalation will do. So try to avoid the drugs and try to give non-drug therapies. Second important, use the drugs only if needed. Use drugs only if needed during pregnancy. Now, what do you mean by that? For example, she has viral infection. You need not give an antibiotic for that. You need not give an antibacterial drug for that. So, viral infections you can treat symptomatically. There is no need to add antibiotics for that. Next, now when you are using a drug, will you use a new drug or a old drug? So, it is advised to use a time tested drug, so which is being used from so many years. We know what it can do, what is that adverse effect. So it is better to use a time tested drug. So please remember, avoid newer drugs. You know the clinical trial. So when we do clinical trial, we don't involve the pregnant woman. So we don't know what is the effect of that on the fetus. So that's why try to avoid newer drugs as much as possible. Now, wherever possible, try to use the local route compared to systemic route. So, systemic drugs compared to local drugs. So, for example, she is asthmatic. Try to give inhalation route, which is a local route, the drug act in the lung. Try to avoid systemic route like drugs like steroids, which are given oral. So, that has to be done. Now, whenever you give, use a shorter acting drugs more than longer acting drugs. So I try to use a shorter acting drug more than longer acting, and use lowest effective dose. So that the adverse effects are minimal, and maximally try to avoid in first trimester. Try to avoid drugs in first trimester. So these are all the important things when you prescribe medicine. First of all, if there is non-drug therapy, give it. Number two, only if it is required, give it, otherwise don't give it. Then time tested older drugs, which is already been established safe, that can be used. Avoid newer drugs. Whenever possible, try to give a local route of administration. Don't try to give systemic route. Then if there is option of shorter acting, give the shorter acting one, and try to give the lowest dose possible, and avoid particularly in first trimester of pregnancy, because that is a time where organogenesis occurs. Okay, sir? We'll follow that. The next important aspect is, how do we know a drug is dangerous to the woman? For that, the US FDA, United States Food and Drug Administration, they have given a category for that drugs. So categories are A, B, C, D, X. Now this is based on the animal study as well as human studies. Category A are very safe. For example, in this we get levothyroxine and folic acid. Category B are safe. Category C are maybe safe. And the category D, is not safe, and category X is having high risk of teratogenicity. High risk of teratogenicity. So these categories, D bar X, you should be very careful when you are prescribing, and category X, they have a highest risk. So when you refer a book called National Formulary of India, you will see the category of these drugs, and based on that, you have to prescribe to the patient. Okay, sir, fine. What is commonly asked in the exam is, for example, a lady comes with hypertension. She is a pregnant woman and she has come with hypertension. Now, what are the safer ones in hypertension? The safer one in hypertension, let me tell you, the mnemonic is let me do care hypertension pregnancy. So these drugs are considered safe during pregnancy. Now, what is L for the drug called labetalol? So labetalol is preferred in pregnancy induced hypertension. The meaning is, due to pregnancy she has got hypertension. Once the pregnancy over, the hypertension will not be there. Me stands for methyl dopa. So methyl dopa is preferred. Suppose a lady is already hypertensive and then she becomes pregnant. So she is already hypertensive, then she becomes pregnant, then the preferred drug will be methyl dopa. Do stands for the DHPs, dihydropyridines, and that is called nifedipine. And remember, nifedipine should be used as sustainability. So the first three drugs are commonly prescribed in practice. Then C stands for safer drug clonidine, and a drug called hydralazine. And what is P for? P for pregnancy. So what is the pregnancy for? A drug by the name prazosin. So these are safer during pregnancy. Remember, pregnancy induced hypertension. Due to pregnancy, if there is hypertension, labetalol. She is already hypertensive, then becomes pregnant, methyl dopa, and nifedipine sustainability. These are the safer ones. Now, what are avoided? What are avoided in her? Avoid mainly these three drugs: AC inhibitors, ERBs, and renin inhibitors. They have proven to have teratogenic risk. So they can cause a problem called renal agenesis. So these have high teratogenic risk, renal agenesis. So they are avoided. Then once we know the pregnancy and hypertension, suppose there is hypertension emergency during pregnancy. In pregnant women, then the drug will be labetalol, because labetalol can be given IV, so that is the best one. If that is not there, you can also use hydralazine, because hydralazine is also safe. You can use that EV, but the best drug is labetalol intravenous that has to be used. Then moving on to another complication in pregnant women. So then moving on to another complication in pregnant women, that is called eclampsia. So they can ask you what is the drug of choice for eclampsia. The name is magnesium sulfate is the drug of choice. So hypertension emergency in pregnancy, the drug of choice is labetalol intravenous. So that is about the hypertension in pregnancy, and most of your exam question is which has the highest risk. The Pril AC inhibitors, sartans, ARBs, and the chirin, aliskiren, they are avoided because they have a highest risk of teratogenicity. Yes. Then moving on to the next condition, epilepsy. Now, epilepsy, the safer ones are, which are known to be safer, they are levetiracetam and one more L, lamotrigine. So, if both are given, the safer alternative will be levetiracetam. Now, question is, what is avoided? Avoid in pregnancy, which has the risk of teratogenicity, is valproate having the highest risk of teratogenicity, phenytoin can produce fetal hydantoin syndrome, and the drug carbamazepine. So these are avoided, and the preferred one is levetiracetam and lamotrigine. And I also told you the drug of choice are eclampsia. Then moving on to the next CNS condition, in management of mania and bipolar disorder, the drugs that can be safer and used are atypical antipsychotics. Atypical antipsychotics. And avoid these drugs which have highest teratogenic risk. What are the drugs avoided? Valproate. Among all the drugs used in mania and bipolar disorder, the highest teratogenic risk is seen with valproate, and then carbamazepine, then lithium. So what is the problem with lithium? Lithium can cause Epstein's anomaly. It is a serious defect. So recently they had asked which one has major teratogenic effect. It is valproate has more risk of teratogenicity. So that is about mania and bipolar disorder. Moving on to the anticoagulation. Anticoagulation during pregnancy. The safer ones are unfractioned heparin or the low molecular weight heparin. The reason is these are big in size and they cannot cross the placenta. If they don't cross the placenta, they don't go to the fetus. Now, what is avoided? The anticoagulant avoided is warfarin. Avoided is warfarin. The reason is warfarin is teratogenic drug. It can cause fetal warfarin syndrome, which affects the bone, nasal hypoplasia, skeletal abnormalities. So avoid warfarin because it is the risk of teratogenicity. You may ask a question, sir, can we use the newer drugs, the DOACs? Now, DOACs we are not studied in pregnant women, so avoid them. Avoid DOACs or NOACs in pregnant. That's why I told you in the beginning itself, newer drugs, until we get the studies, that is post-marketing surveillance, we find out they are safe, they are avoided. So currently they will ask you mainly warfarin should be avoided. Now, one special case they keep on asking every time, suppose a woman is pregnant, she has prosthetic heart valves. So a pregnant woman, she has prosthetic heart valve. What's the problem? If she has prosthetic heart valve, there is always a chance of formation of clot. The clot can embolize and move to the brain and cause stroke. So we need to give prophylaxis. So what is the best way to give prophylaxis? Now, so this is the time she was diagnosed with pregnancy. Pregnancy is diagnosed. So until this is the first trimester, then the second trimester, and then comes the third trimester. Now what we usually do is in first trimester, in this case, we use the safer one, that is low molecular weight heparin. That is a safer one. It doesn't cross the placenta. After the second trimester, we shift the patient to warfarin. Now, what is the reason why we shift the patient to warfarin? Now, I told you the major risk is in first trimester, and we have to give warfarin next, no problem. But why can't we continue low molecular weight heparin? The problem is it's an injection. Second problem is on long-term use, it can cause osteoporosis. So we have to shift the patient to warfarin because after first trimester, the risk of teratogenicity decreases, so warfarin can be preferred. So second trimester also we continue. Third trimester also we continue. But in third trimester, at the end of 36 weeks, we have to shift the patient from warfarin to again low molecular weight heparin. We have to shift the patient again from warfarin to low molecular weight heparin. This is a repeatedly asked question. Sir, why should we do that? The reason is simple. After 36 weeks, anytime she may deliver the baby. And if she delivers the baby, if she is already on warfarin is an anticoagulant. So anticoagulant can increase the risk of bleeding, and if she delivers, the bleeding risk increases, and warfarin is longer acting. So that's the reason we shift her to low molecular weight heparin, which is shorter acting, and even the delivery starts, the action of the drug would have been over till that. So then we shift her to low molecular weight heparin till the delivery. So this is how we do it, and every time they ask this question at the end of 36 weeks, you have to shift a patient from warfarin to low molecular weight heparin. Now, some of the guidelines will also tell, along with low molecular weight heparin, you have to add warfarin first trimester. That depends on the patient. Patient should give the consent. You should tell the patient there is a risk of teratogenicity, whether you want to take it or not. If the patient agrees, the dosage will be lower dose of warfarin first trimester. Otherwise, better to give low molecular weight heparin, then second and third trimester give warfarin. Because one of the beautiful drug to prevent clot formation, valvular heart disease is warfarin. It's a prophylactic drug. So that is what is being repeatedly asked in the exam. Safer one is unfraction or low molecular weight heparin, avoided is warfarin, and in special situation I told you what we are going to do. Then moving on to the next important endocrine condition they can ask you is diabetes. So gestational diabetes mellitus. So what is the best one? The best one is always insulin is the best one. Some books give metformin and glibenclamide, but their studies are still not adequate. So still the best one is insulin. Another important condition is hyperthyroidism in pregnancy. Hyperthyroidism. Let me write. This is the safer one. So whatever writing, I am writing in pregnant women. Hyperthyroidism. If she is in first trimester. So what is the preferred one? The preferred one is propyl thiouracil. Propyl thiouracil. In first trimester, what is the drug avoided? They can ask you. The drug which is avoided is carbimazole bar methimazole. Carbimazole bar methimazole. The reason is they can produce a problem called QT's aplasia, that is scalp defect. They can also cause ovulomesenteric duct anomalies, covalent atresia. So we try to avoid them in first trimester. Now another drug you avoid in first trimester or any pregnant woman, avoid radioactive iodine 131 because it is a radioactive material. It can damage the fetus. So any trimester, don't use radioactive iodine. Okay. Now if she comes to second and third trimester and she is hyperthyroid, then what should we prefer? The preferred one will be carbimazole or methimazole. So the problem here is, why can't we continue the propyl thiouracil only? The reason is propyl thiouracil is having less efficacy, shorter acting, and if you use it for a very long period, it has known to produce hepatotoxicity. And second and third trimester, the risk of teratogenicity is lesser, so we can give carbimazole or methimazole. That is what recently and frequently asked question for. So recently they asked, if you use carbimazole, methimazole in first trimester, what is the problem? Cutis aplasia, or what you call it as the scalp defect. Yeah, this is the point. So once we are done with endocrine, another important is in infections. So in infections, they keep on asking what antibacterial drugs are safe in pregnancy. So antibacterials safe in pregnancy. So the mnemonic is PCM. So what is PCM for? P for penicillin, C for cephalosporin, and M, yes, any guesses? Yes, macrolides like azithromycin, erythromycin, like that. So these are safer. Now what are avoid and carry the risk of teratogenicity? You can remember by the mnemonic FAST. The mnemonic is FAST. Now what is FAST for? F stands for fluoroquinolones. Sir, why fluoroquinolones? Fluoroquinolones can cause cartilage damage. So what happens if cartilage is damaged? Cartilage is required for growth. If you damage that, growth is hampered, fetus will not grow. A stands for the aminoglycosides. So aminoglycosides, the main problem is they can cause ototoxicity. So it can cause ototoxicity in the growing fetus. When the baby is born, it may have the hearing difficulties. S stands for sulfonamides. Sulfonamides, not so much teratogenic. The problem here is sulfonamides. There are two important problems with sulfonamide. Number one, if you are using sulfonamide in third trimester of pregnancy, if the pregnant lady has taken this sulfonamide in third trimester of pregnancy, that drug will go to the fetus. When the baby is delivered, there is a problem called jaundice. Why? Because it will cause bilirubin displacement. And the baby born may have high levels of bilirubin. That is a frequently asked question in your exam. So this was also asked in recent exam. Please mark it. Second, these sulfonamides are contraindicated in patient with these G6PD deficient patients. Now, baby, that is fetus inside, is relatively G6PD deficient. There is a risk of hemolysis. So try to avoid sulfonamide in first trimester. Second and third, no problem. But first trimester, you avoid sulfonamide. There is a risk of hemolysis. So comparatively, it is safer compared to fluoroquinone amylglycoside. It is safer, but try to avoid in first trimester. Last trimester, there is a complication, that is bilirubin displacement. So keep these things in your mind and then prescribe. Okay. Now the T stands for tetracyclines. Tetracyclines, remember, they can cause the damage to the bone, which is required for the fetus. Bone is required, and also the teeth will become discolored. So it will cause teeth discoloration. So you check any years of paper, there is no question, there is no exam without this prescribing in pregnancy. So the antibacterial avoided are fluoroquinolones, amylglycosides, sulfonamides, and tetracyclines. So once you know the antibacterial drugs, another important thing they will ask you about TB. Suppose a pregnant woman is being diagnosed with TB. The first line drugs. In first line drugs, now what is avoided? Avoid the drug pyrazinamide. Avoid the drug pyrazinamide. So it has, the studies are not adequate to tell it is safer. So try to avoid if possible. But which is absolutely contraindicated. Absolutely contraindicated. This question keeps on coming. Please mark this. The absolutely contraindicated is aminoglycoside. What is the first line aminoglycoside? Streptomycin. So they can ask you the streptomycin or the second line injectable drugs like amikacin, capreomycin, kanamycin. So any aminoglycoside, don't give it in pregnant women. So that is about tuberculosis. Now, if a woman has hepatitis B and she is diagnosed with hepatitis B pregnancy, she is pregnant and hepatitis B positive. That time the safer one is tenofovir disoproxil fumarate. So the safer one is tenofovir disoproxil fumarate, is written as TDF. So this is found to be safer in them. The next important aspect in the infections they will ask you is malaria. Now malaria, repeatedly asked question is, what if it is a vivax malaria, and what if it is falciparum? These are the major type of malaria parasite we come across. Now remember, in vivax we use the drug chloroquine. The reason is chloroquine is safe during pregnancy. Now in vivax we have to do radical cure. The drug used is primaquine. So don't use primaquine in pregnancy. Avoid primaquine. The reason is primaquine can cause hemolysis in G6PD deficient patients. I told you the fetus is relatively G6PD deficient and there is a risk of hemolysis, so we don't use it during pregnancy. Sir, then when to do radical cure? When to do radical cure? So radical cure should be done after delivery. After delivery you can do radical Q. For falciparum, if it is first trimester, then the safer one is quinine plus clindamycin. So quinine plus clindamycin is the safer one. Second and third trimester, I told you, relatively safer period. You can shift a patient to artemisinin combination therapy. Artemisinin combination therapy, that is ACT therapy. Another important question in the exam is, suppose she has cerebral malaria or complicated malaria. Pregnant woman having cerebral malaria or complicated malaria, what is the drug of choice? It is IV artesunate. Any trimester, irrespective of any trimester, the drug of choice is IV artesunate. IV artesunate. Sir, can we give sulfonamides in pregnancy? I told you, you have to keep in 2 minds. I mean, you can just cut this. What is the question, sir? Can you use sulfonamides in malaria? Yes, you can give it, but you have to keep 2 points in your mind. Number one, they can cause bilirubin displacement. Second, relatively, there are fetus who are G6P deficiency. There is a risk of hemolysis, so be careful with that. That's it. But usually in second and third trimester, we can give the drugs sulfonamides. But first trimester, avoid it. I will give the classical example here. Toxoplasmosis. Toxoplasmosis. In first trimester of pregnancy, the preferred one is spiramycin. Sir, why spiramycin? Spiramycin is a macrolide. Then if it is second and third trimester, then we can give sulfonamides. What is that? Sulfadiazine plus pyrimethamine. So you can use sulfadiazine plus pyrimethamine, and that is how we manage this case. Suppose a pregnant woman has pain. So what is the analgesic of choice in pregnant woman? Analgesic and antipyretic of choice in pregnancy, which is proved safer, you all know that it is paracetamol. So the NSAIDs are usually avoided. For example, indomethacin. In pregnant women, if you are using it, it is shown to cause the premature closure of patent ductus arteriosus. So this is one important aspect. Another important in GIT. In GIT, suppose she has peptic ulcer disease or gastritis. So what is preferred? The H2 blockers are preferred compared to PPAs. And also antacids are preferred because antacids are not absorbed. So better H2 blockers or antacids are better compared to PPAs if a pregnant woman has peptic ulcer disease. So in this short video, we are trying to cover what are the important aspects you need to remember. And if you see the video and see the questions, everything is high yielding. That's why we made a separate video. I told you, whenever you see a pregnant woman, first of all, give non-drug therapies and avoid new drugs, give time-tested drugs, and try to give local drugs compared to systemic drugs. Then use the lowest effective dose and try to avoid in first trimester. And we discussed in hypertension and other important conditions and what is safer and what is avoided. So that is about drugs used in pregnancy or prescribing drugs in pregnancy. Thank you all.